Hello, everyone, and welcome to our module on movement disorders. Let's start by talking about Huntington disease, which is an autosomal dominant genetic disorder that runs in families, and we'll talk more about the genetics of this condition in just a minute. The underlying cause of Huntington disease is degeneration of the striatum. The striatum is a pair of structures that are part of the basal ganglia, the caudate, and the putamen. So if you look at this drawing on the screen, it shows the major structures of the basal ganglia, which I talk about in detail in their own video. But this is the cortex out here, and in the subcortical region, that's where you find the basal ganglia nuclei. So right here where I'm drawing with my pen, that's the caudate nucleus, and right over here we have the putamen. In between those two structures, you have nerve axons running. Those are called the internal capsule. So the caudate and the putamen make up the striatum. They're found on either side of the internal capsule. And so what happens in Huntington disease is neurons from these regions of the subcortex degenerate, and you lose neurons that produce GABA and also acetylcholine. These are two neurotransmitters. And GABA in particular is an inhibitory neurotransmitter. So when you lose GABA, you get less inhibition of movement, and that leads to excess movement. And so Huntington disease is a classic example of a hyperkinetic movement disorder, and that's in contrast to Parkinson's disease, which is the classic example of a hypokinetic movement disorder. The reason the neurons die in these regions in Huntington disease is believed to be tied to so-called glutamate toxicity. Exactly how this happens is incompletely understood, but glutamate binds to its receptor, which paradoxically is called the NMDA receptor, but it's just the receptor that binds glutamate. And that leads to excessive influx of calcium into neurons, and that's what leads to neuronal cell death. And so the underlying problem in Huntington disease is degeneration of striatal neurons from glutamate toxicity. So as we saw in the last slide, the caudate nucleus sits very close to the lateral ventricles. That's shown here in this image on the screen in a healthy brain. And so when you have degeneration of neurons associated with the caudate nucleus, the lateral ventricles will appear large from caudate degeneration. And that's what you can see in this picture right here of a brain from someone with Huntington disease. You can also see it in this CT image on the slide. Besides enlargement of the ventricles from neuronal cell death, you also get atrophy of the frontal and temporal lobes in Huntington disease, and so those regions can also show atrophy on imaging tests. So as I mentioned earlier, Huntington disease is a genetic condition that runs in families, and the cause of Huntington disease is a mutation in the HTT gene, and the type of mutation that occurs is called a trinucleotide repeat expansion. So let me explain what I mean by this. So normally in the HTT gene, you find a certain number of CAG repeats. And what I mean by this are regions of the gene where the nucleotides cytosine, adenine, and guanine repeat over and over. A normal HTT gene in a family not affected by Huntington disease has 10 to 35 repeats. In families where the genes are abnormal, they can have 36 to 120 repeats. And it's these expanded CAG repeat regions that lead to Huntington disease symptoms. And because of this mutation and the trinucleotide repeats, the symptoms can get worse and occur earlier with each successive generation when the gene is passed on. This is a genetic phenomenon called anticipation, and the reason it happens is because with each successive generation, the gene collects more and more of these CAG repeats, and that leads to symptoms that can be worse or have an earlier onset in life. So the onset of symptoms in Huntington disease is usually in the 30s or 40s at a relatively young age. And the initial symptoms are almost always psychiatric symptoms. So these are things like irritability, depression, personality changes. These things usually occur before any motor symptoms. And usually these things don't bring Huntington disease to mind. So often initially the condition is mistaken for something else, like maybe the person is consuming too much alcohol or abusing drugs. But then at some point the motor symptoms develop, and the classic motor symptom is called chorea. This refers to brief, abrupt, involuntary movements. You can see these in the muscles of the face, also the muscles of the trunk and the limbs. And if you go to YouTube and search up Huntington disease chorea, you can see lots of examples of the chorea, the movement abnormalities that come with this condition. Remember, it's a condition of excess movement. After the person has had the psychiatric symptoms and the chorea for a while, they will usually develop dementia, although this is usually a late finding in the disease. And unfortunately, this disease is progressive and death usually occurs after 10 to 20 years. There are a couple of treatments that can help with some of the symptoms of Huntington disease. And to understand these treatments, you need to appreciate that dopamine is associated with chorea. So drugs that block dopamine will decrease the amount of chorea. So there are two drugs that are classically used for Huntington disease that target dopamine. These drugs are tetrabenazine and duotetrabenazine. Both of them inhibit a transporter called vesicular monoamine transporter 2. This transporter puts dopamine into vesicles inside of neurons so it can then be released into synapses. So by inhibiting this transporter, you limit dopamine's packaging in vesicles and therefore less dopamine gets released. This is basically a way of preventing dopamine release from neurons. Another drug that's sometimes used is haloperidol. I talk about this drug in the psychiatry section. It's an antipsychotic medication, and it's an antagonist to dopamine receptors in the central nervous system. Okay, moving on, let's talk about another movement disorder, and that's the disorder hemiballism. So this refers to wild flinging movements of the extremities, so-called ballistic movements, and they occur on half of the body. That's why it's called hemiballism. And the way you get this disorder is by having damage to the subthalamic nucleus, which is one of the components of the basal ganglia on one half of the brain. And this is seen in rare subtypes of lacunar strokes. Basically, the only thing you really need to know about this disorder is that it's associated with damage to the subthalamic nucleus. Okay, let's talk briefly about Wilson disease. I have an entire video on this condition in the GI section, but by way of review, it's a disorder of copper metabolism where copper accumulates in tissues, and copper can accumulate in parts of the basal ganglia. Usually copper accumulates in the so-called lentiform nucleus, which refers to the combination of the putamen and the globus pallidus. Once again, if we look at this drawing of the basal ganglia structures, they're found here in the subcortex. And this whole structure right here is the lentiform nucleus. It includes the putamen, which is this part here, and the globus pallidus, which is this part out here. Patients with Wilson disease get a number of symptoms from copper deposition in tissues throughout the body, but some of those symptoms are movement symptoms related to the basal ganglia. The classic finding in the 1 to No for your board exams is a so-called wing beating tremor. This is a tremor of the arms that's worse when the patient stretches their arms out and flexes their elbows. They will flap their arms as if they are beating wings. Patients also often develop dysarthria, which is a speech abnormality related to the basal ganglia with slurred, mumbled speech and words. Okay, moving on, let's talk about myoclonus, which refers to brief, shock-like involuntary movements of muscles or limbs. These are transient developments. Myoclonus is brief, it comes and goes very quickly. Importantly, the involuntary movements are not rhythmic, like chorea, which we talked about earlier, associated with Huntington disease. They're also not sustained. Sustained involuntary movements are called dystonias, and we're going to talk about those in just a minute. So myoclonus can be a normal physiologic condition that occurs in normal patients. If you've ever been about to fall asleep and you had your arm or your leg jerk, that's evidence of myoclonus associated with sleep. Hiccups are also an example of myoclonus involving the diaphragm. There's a rare condition called essential myoclonus where patients have recurrent episodes of myoclonus with no other neurologic illness. You can also have epileptic seizures associated with myoclonus. And then lastly, patients who have encephalopathy from advanced renal failure or advanced liver failure, they often develop episodes of myoclonus associated with their underlying kidney or liver disease. Okay, I mentioned chorea before related to Huntington disease, which is one condition that can cause chorea, but let's talk about chorea in general now for a minute. So as I mentioned earlier, chorea refers to involuntary, brief, random, irregular contractions. If you ever meet a patient with chorea, and I've met one or two in my career, they will simply appear restless. They're just shifting in their seat, moving their arms and limbs. Chorea can be idiopathic. There are rare hereditary forms, or it can be part of another disorder like Huntington disease, which we talked about earlier. And basically, chorea is part of a spectrum of so-called hyperkinetic movement disorders that I've listed here in this table. So chorea is involuntary, brief, random, irregular contractions of limbs and muscles. Athetosis refers to slow, writhing, snake-like movements. We'll talk more about that in a minute. You can sometimes see that in children who have rheumatic fever. And then chorioathetosis is a hyperkinetic movement disorder where there are features of chorea and features of athetosis. And then lastly, ballism or hemiballism is another hyperkinetic movement disorder. We talked about this earlier. This refers to large amplitude movements of arms and legs with flinging and kicking. There are basically two important causes of chorea that you should be familiar with. The first one is Huntington disease, which we already talked about. The other one is Sydenham's chorea. This occurs in children with acute rheumatic fever. I mentioned this earlier. So acute rheumatic fever is a consequence of group A streptococcal infection, basically a sore throat that doesn't get treated for the bacterial infection. This can lead to antibodies that react with neurons, causing autoimmune disease. And that's what acute rheumatic fever is. I talk about rheumatic fever in detail in other videos, but for this video, we'll focus on the Sydenham's chorea features of acute rheumatic fever. So children who have this condition develop rapid, irregular, purposeless movements. They flow randomly between muscle groups. And the best way to understand this is to go to YouTube and search up Sydenham's chorea in rheumatic fever. You'll see videos of children who have this condition and they're moving their arms and legs in a sort of rhythmic way that flows from one side to the other, where one arm moves, then the other arm, then one leg, then the other. Okay, moving on, let's talk about dystonias, which are involuntary muscle contractions that are sustained and prolonged. And this is important. So all dystonias involve either a prolonged contraction, like writer's cramp, which is shown here, where the hand muscles are stuck in a prolonged contraction, or they involve sustained repetitive contractions. That's what blepharospasm is, which we'll talk about in a second, where patients' eyes blink uncontrollably over and over again. It's a sustained phenomenon. And this is in contrast to myoclonus, which we talked about earlier, which is a single rapid jerk. Dystonias are different. They are sustained and prolonged. They can be focal and involve just one region, like the hand shown here. Sometimes they are segmental, and they're often associated with overuse of muscle groups. When muscle groups are overused, like the hand in the case of writer's cramp, that can lead to a dystonia. So there are a couple of common dystonias you should be familiar with as a medical student. You could see these clinically, or they might come up as a single question on your board exams. One of them is cervical dystonia. This is also called spasmodic torticollis. This is basically an overuse injury of the neck, where the neck gets stuck in a position where it's turned with the head tilted and the patient can't relax the muscle. Blepharospasm I mentioned on the last slide. This is an involuntary blinking of the eyelid or eye closure where the patient can't open it. This sometimes occurs when patients have overused their eyelid muscles. Spasmodic dysphonia is a dystonia where the voice breaks and it interrupts normal speech from overuse of the voice. Oromandibular dystonia is when the jaw gets stuck in a clenched position, and lingual dystonia is when the tongue gets stuck in a protruded position. And then finally, there are so-called task-specific dystonias like writer's cramp, where the patient's hand gets stuck in a position like we saw on the last slide from overuse. There's also a variant of this called musician's dystonia that occurs when patients overuse their hands to play a musical instrument. Okay, let's finish this video by talking about tremors. There are lots of different kinds of tremors, but I've listed 3 important ones on this slide that you should know. The first one is a resting tremor. This is a tremor that occurs at rest. It usually involves the hands. It gets better when the patient intentionally moves their hands or arms. And this is the classic type of tremor in Parkinson's disease, which I talk about in another video. An intention tremor is a tremor that gets worse when the patient moves their finger toward an object. It's basically a zigzag motion when they're trying to move the finger towards the target. It can be absent when the patient starts the motion, but as they get closer and closer to the target, for example, if you ask them to touch something with their finger, as they get closer to the target, the tremor will get worse. And this is what you see with cerebellar dysfunction, which I talk about in other videos. You can test this at the bedside with the finger to nose test, where you ask the patient to touch their own nose and then touch your finger and go back and forth. That will bring out an intention tremor. And then earlier I mentioned a wing beating tremor, which is a classic tremor associated with Wilson's disease. This is a tremor involving the arms and hands. This tremor is elicited by asking the patients to put their arms out at their sides and bend their elbows, and then they will basically clasp their hands together like they're flapping their arms and hands together like wings. Okay, and then one final type of tremor you should be familiar with is called essential tremor. This is a tremor disorder that usually involves the arms and hands, but it's not usually present at rest, and that distinguishes this from the tremor of Parkinson's disease, which is classically present at rest. Essential tremor is a type of kinetic tremor. That means it's worse with kinetic movement, voluntary movement. So when the patient tries to do things like write or hold up a glass and drink, this will make the tremor worse. It's also an example of a postural tremor, so it's worse when the patient tries to maintain a particular posture. This is often elicited by asking the patient to hold their arms outstretched. Their hands will start to tremble because this is a postural tremor and they can't hold that posture. Essential tremor is considered a high-frequency tremor. Usually the arm or the hand will shake at a rate of 6 to 12 hertz, which means 6 to 12 times per second, and this is a fast tremor. In a board question, for this reason, it will often be described as a fine tremor. That's just another way of saying that the tremor is very high frequency and fast. Alcohol classically improves this tremor for reasons that are poorly understood, and some patients will self-medicate. They will find that alcohol makes the tremor better, and so they will drink alcohol for this reason. There's a genetic predisposition to this tremor, so it runs in families. In fact, this sometimes used to be called a form of a familial tremor for that reason. And this does usually respond to one particular drug treatment. That's with propranolol. It's a very old non-selective beta blocker, and it's been shown to be effective for this type of tremor, essential tremor. And that concludes our module on movement disorders.